My name is Toby Lewis. I am a pediatric pulmonologist with a special interest in asthma. I'm originally from the East Coast, have been here in Michigan for 20 some odd years. I'm currently the director of the complex asthma management program here at U of M. And so my personal practice is the tough asthma kids. So I'm seeing a different slice of the pie than what you see in primary care. But I am also working with the INHALE CQI collaborative as their pediatric asthma expert. And so it's sort of wearing both my regular pediatric pulmonary hat and as part of INHALE that I'm here with you today to talk about spirometry in particular as it relates to kids, because I think we get a lot of messaging that's really geared towards adults. And so I'm trying to
you'll have to prime it.
Bring it to us as pediatricians. And so I've got a PowerPoint prepared to sort of get us oriented. Megan had forwarded to me a few questions that she had collected already. So I've prepared some answers to those, but I'm hopeful that we'll have some additional time at the end just to have a back and forth conversation. I'm trying to be clear about when there is a guideline recommendation and when it's a personal recommendation or a personal practice preference. There are data in kids, and so I'm trying to be respectful of that, but I think the challenges are also just applying the evidence to our everyday practice and trying to fit it in, and which I think is something that we all struggle with as clinicians. So without further ado, I am going to try to share my screen, and I've got two screens going, so hopefully I'll get the right screen. All right, so you should be seeing my PowerPoint. Is that?
Yes, we are.
All right, and then let's start the show. All right, I am not going to monitor the chat, but if anybody feels like they need to interrupt or let me know, somebody keep an eye on the chat, let me know what's going on. So the topic today is the role of spirometry for pediatric asthma primary care. Rather than talk about what is spirometry or how to do spirometry in primary care, I'm really going to talk about how do we integrate spirometry into the practice of primary care for kids with asthma. And I'm going to put this in the context of the changing asthma care guidelines, spend a few minutes just talking about that, discuss the current guideline recommendations for spirometry use in asthma diagnosis and management from the two main guideline organizations. Talk a little bit about how I use spirometry and some other lung function testing in my practice, and then focus on question and answers. And again, I've got a few questions that I was provided with beforehand, and hopefully there'll be some free time. And then at the end, I've got some references, and I will make my slides available to Megan so that she can distribute them so that everybody can check into those references. Okay, so what is the challenge that we're dealing with where spirometry might be able to be helpful? So the first has to do with diagnosis. And when I was in training back in the late 80s, early 90s, the concern was underdiagnosis of asthma and needing to make sure that we were casting a wide enough net to recognize asthma when we saw it. I think now the pendulum is swinging a little bit the other way, and there's concern that all sorts of kids have been labeled as having asthma, and maybe it's not really asthma, which then gets into what is asthma and how do we define it, and are we going to split out all the different subtypes, and do we think of wheezing preschoolers as asthma or not? There's a lot of nuance there, but the idea is that we want some objective help to make sure that we're appropriately making the diagnosis of asthma. And then the second issue has to do with monitoring asthma and the fact that patient reporting of dyspnea may not match the level of objective airflow obstruction. And in pediatrics, that could happen for several reasons. So the patient themselves may overperceive their sense of breathlessness. They may underperceive it. I think we've all seen those patients who like walk into the office, I feel fine. And yet they're, you're hearing wheezing, they're showing objective signs of airways obstruction. We also deal with third-party assessments. There's parents or other caregivers trying to give us report on what they think their kid is experiencing, and that's different from what the kid may actually be having. And we're always having to interpret or translate the reports that we're getting. And then finally, I think all people, but especially kids, have a hard time finding the words to describe what the physical sensation is. And we'll get all sorts of descriptions that may or may not ring a bell as dyspnea for the practitioner. So where spirometry and other objective measures of lung function can help is to confirm reversible airflow obstruction as part of our diagnostic testing, and also to help us understand response to therapy and current day health. So there's an initial diagnostic piece, and then there's an ongoing management piece. So just digressing a little bit into the guidelines that we have to help us systematically figure out who needs spirometry, when, and how. The guidelines that we've used in the US for the longest time have come through NHLBI. It's the National Asthma Education and Prevention Program, or NAEPP. There's been 4 iterations of this guideline. The last comprehensive guideline was EPR 3, which came out in 2007. And then there was a focused update that just happened in 2020 that focused on 5 key questions, none of which were spirometry, but one of which was FeNO. The methodology used here is very rigorous, and it's very time consuming. So the 2020 updates that we're looking at now in year 2023 are based on literature that was published up through the end of 2018. So it's already a little bit out of date. So keep that in mind. There's a good reference that summarizes these recommendations, and I've got that in the reference list at the end. There are 2 documents that distill kind of the key messages from NAEPP. You probably already have these. There's a link for how you can download these. We print these out in pediatric pulmonology and have them plastered on our walls, and we refer to them all the time. And then I also want to mention GINA, or the Global Initiative for Asthma. You may already be aware of this, but many primary care folks are not. So this is the alternative agency or group that develops and disseminates asthma guidelines, really designed for an international audience. NHLBI and American scientists do contribute to this. So you get some of the same people contributing to both guidelines. This is currently the international standard, and I would say increasingly is getting adopted here in the US. It is similar but not identical to NAEPP, and this can cause some confusion. And so right now we're in this weird middle ground where we've got 2 different guidelines, and each guideline has strong recommendations and alternative recommendations, and it's sort of all valid right now, but that can be very confusing for practitioners. The thing about guideline is that it's updated annually. They are a little bit more nimble about incorporating new info. Currently, we have 2022 guidelines for GINA, and that reflects literature pretty much up till 2021. They're just about to come out with 2023 guidelines, which will incorporate 2022 information. So anything post-COVID, you're going to find it in GINA. You're not going to find it in NAEPP. This organization also has a pocket guide with stepwise treatment plans. And I would say I anticipate that over the next 5 to 10 years in the US, GINA is going to supplant NAEPP. So if you're not already aware of this guideline, it's worth getting to know it. The reference that I would recommend for you is a recent publication in February of 2023, so just a couple months ago, reviewing, sort of extracting from the GINA 2022 guideline, the key recommendations for primary care. And they do kind of tease out kids down to age 6. They don't deal a lot with the preschool wheezers, but this I thought was just very pragmatic and very practical. And some of the authors here are US well-known asthma experts. So I do believe that US primary care is going to start using this as a basis for practice. All right, so what do the references say? So the last time NAEPP really dealt with spirometry was the last comprehensive review, which was in 2007. And there's a blanket statement that it recommends spirometry to help assess asthma severity and control and to assess response to therapy. And in terms of frequency, it's recommending measurement at the time of diagnosis and annually thereafter, at least annually thereafter for monitoring. And they make a note to say that children with mild or intermittent asthma are expected to have normal spirometry on an average day. So normal spirometry does not exclude the diagnosis of asthma. And that's really important to remember. Meanwhile, GINA, in their most 2022-2023 recommendations, is really pushing the incorporation of spirometry for primary care. A lot of this is driven by adults where there are many more alternative diagnoses, especially trying to distinguish asthma from COPD. But it is also emphasized for pediatrics on this issue of over and under diagnosis, especially on the overdiagnosis side. But even GINA says to remember that there's no single test that confirms or excludes the diagnosis of asthma. So it's really a part of the puzzle. It's not exclusive. Still, it is necessary to have a compatible history of respiratory symptoms and/or exam findings that are consistent with asthma. And the key is the variability over time and the reversibility of the airflow obstruction. In the GINA guidelines, there is a prominent role and increased emphasis on documenting the objective measures of reduced airflow obstruction and the variability. And the recommended parameter is FEV1, which has to be obtained with spirometry measurements, but they do offer peak flow as an alternative, especially in low-resourced areas. So remember, this is an international agency for the world, and so there are a lot of situations where there just are no spirometers. So the particular parameters that they're asking to document are either at a time of symptoms, a reduced FEV1 to FVC ratio of less than 90%, a bronchodilator response. So if I give albuterol, and to translate this dose, it's 2 to 4 puffs of albuterol, seeing a 12% increase in FEV1. Or alternatively, you can send somebody home with a peak flow meter, have them assess twice a day for, they recommend 2 weeks, but for at least 1 week, calculate the average diurnal variability, and they give you the formula for how to calculate that. And if you have basically variability in your peak flow between your morning and evening measurements of greater than 10% in older people and greater than 12% in younger kids, that's considered supportive objective measures. And then the final way you can do this is with a bronchoprovocation test, methacholine, exercise, cold air, and seeing a drop in FEV1 of 20% under standardized conditions. There's a table in or a flow chart in there for how you would make the diagnosis of asthma. And just briefly to say, to highlight this, at the top, you have a patient who's presenting with typical respiratory symptoms. You do a detailed history and physical. They ask, is the patient already on a controller therapy? And if they are, they sort of shunt them off to a slightly different algorithm. But if you're naive to any controller therapy, the next step is to perform spirometry or peak flow and document variability or reversibility, and then they go on from there. So that's where the recommendation is right now. So for me personally, I rely heavily on spirometry. For me, it is a key assessment tool. During the pandemic, when we weren't doing spirometry because we were worried that we were spreading COVID through the testing, I felt like I had both hands tied behind my back. It was really a cramp in my practice style. We typically start assessing kids at around 5 years old, though we expect that it's going to take some practice before we're getting quality measurements. I have the luxury of having full body plethysmography and diffusion capacity and oximetry and a whole battery of tests that I can do when I'm trying to do diagnosis. And remember, I'm getting referred the tough diagnostic dilemmas. But I think for primary care, standard spirometry is plenty, is sufficient. And I use it all the time for ongoing management. So for every office-based asthma visit, I'm getting spirometry. These days when we're doing more video visits, I obviously don't have it. And so it's one fewer assessment tools that I have. Now, I also on video visit can't listen to the lungs. So I've got 2 fewer assessment tools. So that belies my preference for in-person pulmonary assessments, but that's a whole nother conversation. In terms of acute assessment, so if somebody comes into my office saying they feel sick today, I will try spirometry. If I'm seeing them in the ED or the hospital, usually they're too dyspneic to do it. And so it's not a routine part of my acute asthma care and assessment. But personally, if kids have been hospitalized before they go home, I like to get lung function testing. Sometimes kids are all the way back to normal, and that's really reassuring. Sometimes they're not, and that can be very helpful for communicating with the family about why it's important that they maintain their controller therapy, why they need follow-up, and so on. All right, role for peak flow monitoring. I think most pulmonologists would say this is not for your average patient all the time routinely. It can be confusing to learn the proper inhaler technique, which is an inhale technique, and also learn the proper exhale technique for peak flow monitoring. People don't like doing it, they forget it. So it's not a standard, but there are some places where its targeted use can be really helpful. So as I mentioned before, if you need help with diagnosis, sending somebody home with the peak flow meter and doing twice daily testing for a week or 2 can help you document diurnal variability. If you're setting up an asthma action plan, and typically we would give symptom-based guidelines for how you know you're in the yellow zone or how you know you're in the red zone. But for some people, having objective numbers can be really helpful. peak flow meters can be really useful there. And then for some kids, I recommend it for routine use, particularly those who need an early indicator. So the populations that I would use it for are the kids who seem to go from 0 to 60, like in a couple of hours, right? I'm fine 1 minute and I'm struggling the next. Those kids might benefit from regular monitoring of peak flow, because then they can know when they're starting to dip before they even feel it. Many teens, I think, are poor perceivers, like they just don't register what the airflow obstruction feels like. They're not trying to deny it. They're not trying to skip out. They just don't feel it. Or
Dr. Lewis, I'm so sorry. I'm going to cut in for just 1 moment. If you are, could you guys all please mute your computers? We're getting a lot of background noise right now. Thank you very much.
all right. Well, so just to summarize, kids who get sick quickly, who might need an early indicator, kids who seem clueless, is the way it comes across to the adults. I didn't realize that I, had an FEV1 of 60 or something, or just attention issues, right? I'm going a mile a minute. I want to go out and play. I'm not paying attention to how my body feels. And then in the new treatment guidelines, there is a new paradigm where we're using more symptom-driven inhaled steroid use. Well, in order to use inhaled steroids when you have symptoms, you have to know when you have symptoms. So some people feel it and recognize it, but other people need the objective measure. So those are places where peak flow monitoring can be really helpful. All right, what about fraction of exhaled nitric oxide, or FeNO? So I really consider this supplemental. For some kids, it can really be a leading indicator, either in both directions, either that they're slipping asthma control or that we're finally gaining on it and starting to get some improvements. I have some other kids who their FeNO is low. It's always low. It's very dysynchronous with their other indicators of airways obstruction or inflammation, and those kids, I don't find it very helpful. There is a technique that requires steady low flow exhalation that can be a little tricky for the younger kids. I usually start testing around 8 years old. Sometimes, it's 10 or 12 before kids can really get the hang of it. The programs that have graphical interfaces and show, like in this picture, there's a balloon that's going up and down based on how hard you're blowing, and there's an ideal range that you have to maintain. So the visual interface can be really helpful for getting a good measurement here. Just to mention that the NAEPP 2022 updates that were focused on 5 key questions. One of their key questions was, what's the role of exhaled nitric oxide? There's a lot of words. The bottom line is it can be helpful in certain circumstances, but the evidence is still plus minus. All right, a quick note on just other diagnostic tools. So the way I was taught back in the day was using an empirical trial of therapy. So you've got a kid who has compatible symptoms. They may be fine today. They look good. They sound good. But you get reports of every time I have a cold, I cough nonstop, or I have exercise-related symptoms. Oftentimes we will try prescribing asthma therapy and assessing whether that makes a difference. I use this a lot. I will say I am using it in conjunction with spirometry. The key is to clearly define the time frame that you're going to be looking over and define your endpoints. So that may be spirometric endpoints, or it may be whatever the clinical symptom you were presented with is. In the guidelines, they do acknowledge that this is an appropriate response, but I will say, as I've watched the guidelines evolve, this is getting de-emphasized. So I think we're still safe doing this under certain circumstances, but just recognize there's going to be increased expectation from the guidelines that we roll in objective measures wherever we can. The controlled provocation challenges, the two most common ones that we do at Michigan are exercise challenges and methacholine. These can be very helpful when there's diagnostic questions remaining. It's not for everyone. They're a pain in the neck to schedule for your patient. They take time and they're not necessary, right? You don't need one of these in order to make a diagnosis. But if you're trying to distinguish between asthma and a conflicting diagnosis, or you think you might have two things, asthma and something else, this can be very helpful. Again, this is looking at bronchial hyperreactivity, which is one of the hallmarks of asthma. It's not looking at airways inflammation, which is a different set of assessments. It's especially good for teasing out vocal cord dysfunction. The other term for that is paradoxical vocal fold movement. And then there's a more elaborate exercise test that includes metabolics that can be useful when you've got very complicated kids who may have cardiac or autoimmune or hematologic abnormalities. By the time you're considering that, you've pretty much also decided that you're referring to a specialist or multiple specialists. And just to make you aware, there's several new technologies that are on the horizon. So increasingly, there are home spirometers that are caught, like right now, they're sort of $200-ish, but they connect to an app on your phone, and there's ways that you can send your results to your doctor. There are also specific inhalers that have digital monitoring embedded in the inhaler and connect to an app. So the picture on the left is a brand name device called DigiHaler, which will both monitor when you take a puff, but also the inspiratory flow that you use to suck the medicine out of the device. That can both give you feedback on technique, but also if you're acutely ill and you can't mount the required inspiratory flow, it'll flag you and it can flag your doctor. The device on the right is like a little cap that you can put on any inhaler that will monitor not only that you took your meds, but where you were and when. And so if you're trying to track triggers and what's prompting symptoms, that's an added little gizmo. So I think, again, the trend for the future is that we're going to be using technology more in the home, and that's not in the guidelines yet, but I think that's coming. All right, so moving on to some questions, starting with the ones that I was provided. So one of the questions was, for a patient clinically well-controlled on maintenance therapy, how often would you recommend spirometry? Does your recommendation change based on the severity of asthma or the green zone medicines that the patient is on? So again, for me, I would recommend spirometry every time you're doing an office-based asthma assessment, if you have that available to you, if it's in your office. What the asthma severity or the intensity of treatment changes for me is how often you're going to be seeing that patient back, right? So the well-controlled patient you're comfortable with the diagnosis and they've been on a stable level of therapy, you might be seeing that patient only once a year for an asthma checkup. It might be wrapped into their well child check. or you might be seeing them twice a year as you're preparing, usually a fall and spring assessment, preparing for school or dealing with the midwinter crud. I think if you do not have spirometry in your office, I would say annually or once every other year, referring into a lung function center or place where you can get it. I know from the INHALE CQI place where we're thinking about how are we going to provide information and feedback to practitioners so that they know how they are doing and how they stack up to other practices. I think our current measure is using a 2-year window. Have you done spirometry in the last 2 years? There's potential as the guidelines change that may narrow down to 1 year. But for your less well-controlled patient, or for the patient that is having multiple exacerbations or has had a severe exacerbation in the past, they've been hospitalized, they've been in the PICU, typically I'll see that patient at least twice a year, if not 4 times a year, for quarterly assessments, seasonal assessments. And sometimes if they're changing rapidly, I'm seeing them every other week, just because we're changing things and we're trying to stay on top of things. So it's really about the control level that you have for your patients. And so what am I looking at when I'm looking at spirometry? So first of all, I want to make sure that what your report of how you're feeling today matches what I can measure. Many times they're the same. You say you're good, your numbers are good. You say you feel bad, your numbers are bad. But every now and then there's a disconnect. And so knowing, I would say it's not rare. I would say probably a third of the time, I'll see a disconnect between what my patient is telling me and what I'm measuring on spirometry. So that can be very important. For the patient who's been on stable therapy where I'm thinking about stepping down, I want to confirm that you're okay before I step you down. And then when I step you down, I want to bring you back in a period of time. For me and my practice, it's usually every quarter, so every 3 months, but it could be more frequent than that. I want to make sure that I didn't lose asthma control, right? Especially if it's subtle and you're not complaining about it, or maybe you had 1 exacerbation. Is that a fluke, or is that because your lung function is slipping? Those are the kinds of questions I'm trying to answer by looking at spirometry. Another question, in a patient with suspected exercise-induced asthma, is pre and post albuterol spirometry often adequate to make a diagnosis? And if spirometry in this case is normal, should an exercise challenge be attempted in the office? So these are all great questions, but this one is complicated, and I could give an hour talk on exercise-induced bronchospasm. And how we assess it and what it means and how you manage it. I will just make the statement that kids who get bronchospasm with exercise, that's exercise-induced bronchospasm, there is a distinction made between EIB alone, that's the only time I have symptoms, and people who have bronchospasm of and airways obstruction at other times in addition to exercise. So that would be considered asthma with EIB. In the older version of the guidelines, treatment was different. You would treat EIB alone differently than you would treat asthma with EIB. With the newer guidelines where we have symptom-driven inhaled corticosteroid use, the line is blurring and the treatment approaches are more similar. So when reading the literature on EIB, it matters when the article was published. So before 2019, which was when GINA started really changing its guidelines, there's a bigger distinction. Since 2019, less so. Okay, that's background. The bottom line is, if you've got somebody who has exercise-related symptoms and you give them a bronchodilator to use before exercise and they get better, to me, I'm satisfied with that. That's the empiric trial of therapy. I didn't, because I don't have spirometry out on the field, or when my patient is running. I'm comfortable diagnosing EIB in that circumstance. If I have you in the office and you have normal lung function and I give you albuterol and your lung function goes up, that's bronchodilator responsiveness, and that diagnoses you with asthma, right? So that's not EIB. I haven't exercised you. I've just taken your baseline state, given you albuterol, shown there's a response of a significant amount, and that gets you the diagnosis of asthma. So to the first part of the question, is a pre-post albuterol spirometry that documents asthma sufficient? Absolutely. But if you do the in-office pre-post albuterol and there's no difference, and I've given you albuterol to try on the field and there's no difference, that's when a bronchoprovocation test would be helpful. There are fairly standardized methodologies for doing that we use in our pulmonary function lab. Again, I know I've practiced in some lower resource communities where we didn't have that ability, and we used to run the kids up and down the stairs, right? We would say, okay, go out here, run up and down the stairs 10 times, we'll come back and we'll repeat it. So what I would call the sort of poor man's exercise test. That is not officially approved or condoned by the guidelines, but I would be the first to say I've done it. You just have to be prepared for the fact that it's not standardized. So you have to take a negative test with a grain of salt, right? You haven't documented that you've achieved the level of exercise that would be expected to cause the bronchoconstriction. Here is a very interesting article. I've also referenced it at the end that gives a little algorithm and when you would consider some other testing. All right, here was a question. What do you do with restrictive spirometer patterns, especially in a known asthmatic? Mm-hmm. And this is where I get to put on my physiology hat and go back to pathophysiology. So if you'll remember body box or body plethysmography, and which is a more extensive form of lung function testing. So spirometry, I'm asked to take a maximum inhalation, fill my lungs, breathe out as hard and fast and as long as I can, and exhale everything that I have control over out into the mouthpiece. The computer measures that as vital capacity, or FVC. What's left over in my lungs after I've completed exhalation is the residual volume. You can't measure that with regular spirometry, but I can measure that with body box. These diagrams graphically represent total lung capacity, which is the sum of what I can voluntarily control versus the vital capacity, plus the residual volume, which is what's left over in my lungs when I'm done exhaling. So on the far left, you see usually residual volume is about 20% of the total. True restriction, I had to put in on the far right. That's my little graphic, where the whole total lung capacity is reduced. So everything is small. The residual volume is small, the vital capacity is small, the total lung capacity is small. That's typically what we think of when we get a low vital capacity measurement on our spirometry. We think, oh, you have a small vital capacity. But for somebody with asthma, there's another possibility, which is what they call pseudo restriction or air trapping. So in this situation, my airways are narrowed. So I can take a full breath in, my chest expands, my airways expand, I can inhale great. But when I go to exhale, that forced maneuver, my chest is getting smaller, I'm compressing those airways, the already inflamed bronchospastic airways are getting squished even more, and they get to the point where they close off completely sooner in the exhalation. So as a proportion of the total, less is escaping and getting out into the computer, and more is getting held on or trapped inside my body. So my residual volume is very high, and that sort of squeezes out the vital capacity. So what the computer measures is a small vital capacity, but it's not because the whole or the total is small. It's because I can't exhale completely. So if you have a known asthmatic who all of a sudden you're getting a low vital capacity on, my first inclination is to say that's an indicator of airways obstruction, and I would manage that as asthma not being well controlled. That's different from the diagnostic situation where I've got a kid who's complaining of shortness of breath, and I'm doing spirometry for the first time, and I'm seeing this reduced vital capacity, and I don't know which I have. Do I have that pseudo restriction, or do I have true restriction? So in that case, the next step is to give the bronchodilator and to look for bronchodilator responsiveness. And sometimes when you do that in the office, the airways will open up, you'll be able to exhale better. And the second time when you repeat the spirometry, now all of a sudden your vital capacity looks more normal, and then you all of a sudden start seeing the scoop in the classic scoop and the lowered FEV1. So if you do that, if you do the bronchoprovocation, sorry, that's my phone in the background, that I think is sufficient. You don't need to do anything else. But if the giving albuterol doesn't change things, then you have to worry that you really have a true restrictive problem. And then I think you're referring to a specialist for the full lung function, so you can actually measure residual volume and you can do more diagnostic testing. I think this is, I may have one or two more. I think this is the last one. In a patient with suspected post-COVID dyspnea, how helpful is spirometry in establishing a treatment plan? So first of all, remember, I love spirometry. I find it incredibly useful in helping me understand what's going on with my patients. So I would recommend for the patient who comes in with persistent symptoms after COVID or any viral infection, I would recommend doing lung function testing and a chest x-ray, because that's just going to put me on the map in terms of what am I dealing with. Sometimes that can be really reassuring. You know, it's not that the patient doesn't have something going on, but hey, you've got normal lung function and a normal chest x-ray, that's reassuring. Or if it's not normal, that gives you an avenue or something that you can treat. Just giving more perspective on post-COVID in particular, the follow-up that's been documented both in the literature and in our experience at U of M, most of the post-COVID patients with dyspnea will have normal lung function. So most of the time, you're not getting anything actionable from that. But a significant minority will have some airways obstruction, and then typically we would put people on inhaled steroids. But we do not, I'll just tell you our practice at U of M, we would not necessarily diagnose them with asthma. We would call that a post-viral airways inflammation. We would try to take them off the inhaled steroid down the road, and then if the airways obstruction returned, then that would get them the diagnosis of asthma. I just pulled out a results section from one recent paper published in 2022, reporting on the 2021 experience at Nationwide Children's in Columbus. So they had 82 teens who had persistent dyspnea at least 4 weeks after COVID, who were being followed up more than 3 months later. And 77% of them, so almost 80%, had normal lung function. Approximately 15% had obstructive deficits, and 5 patients, they didn't calculate that, percentage-wise, had restrictive deficits. Some of these people had asthma, but they didn't have pre-existing asthma, but they didn't have pre-existing spirometry on these patients. Of their 82, they gave them all bronchodilators, and 31% had a positive bronchodilator response. So there's a 10% of the people who had normal spirometry, when they gave a bronchodilator, they got better significantly. You know, roughly 20% came in with low lung function, and they give them the bronchodilator and they get better. All right. So, yep, that was my last question.